Dr. Beje Thomas from the MedStar Georgetown Transplant Institute. Dr. Thomas is a graduate of LaSalle University. He attended medical school at University Debrecen in Hungary. He completed his residency at the University of Connecticut and then stayed on to serve as a chief medical resident. He completed his fellowship in general nephrology at UConn. And then he added transplant nephrology year at the Medical University of South Carolina. He served on the faculty at the University of South Carolina and later at the University of Maryland. He was recruited to Georgetown in 2018, and it's been really a wonderful addition to our faculty. He's quickly been recognized as an outstanding educator and clinician. He's actively involved in training fellows, residents, and medical students. He participates in our physical diagnosis course, have formed our Diversity, Equity, and Inclusion Committee here in the Department of Medicine. This group has identified several goals, including the need for education, recruitment and support of underrepresented minorities within the Department of Medicine. Members of this team from that organization and other people on our faculty and house staff are also serving on many of the MedStar-wide diversity committees. And so I want you to all know that our internal medicine has a strong presence at the table as we determine future best practices for our entire organization.
Thanks, Dr. Walton, for your kind words. And I'm just a small part. Everyone's doing some really, really great work here. So we're actually going to switch to acid base. No, I'm just kidding. I'm just kidding. So I want to take a moment with everything that's happened recently. This is the late Congressman John Lewis. Some of his favorite quotes are up here. I want to take a few moments to remember those that have lost their had their civil liberties violated, and also those that have fought for civil liberties. Right. So I know everybody knows that I like my QR codes. So this is a code. If you put your Apple iPhone on, turn the camera towards it, or if you have an Android, you can certainly put your QR code reader to it. You'll get the PowerPoint, and I'm happy to email it out later, and some other pretty good resources as well, just a few articles and stuff. So I'll give you a few seconds here. And if anybody wants to learn how to do this, I'm happy to teach you how to use Dropbox to do this as well. All right, here we go. So first disclosure, I'm a student as much as all of you are. I'm learning as we go through this. The Bias Reduction Improvement Coaching Program I'm part of, mentored by Dr. Dean Cheng and Dr. Christy Graves. They're awesome, amazing opportunity to do these kinds of talks. This is a safe place. Some of the things might be controversial. I hope I don't offend anybody. Some of the thoughts you might have are uncomfortable, but it's okay. We're trying to grow together so we can have a better system here. The agenda, so I always love these slides, but my goal is not to per se try to kill you with 100 slides, but just so everybody can come away with some reasonable points and summary points. So we'll go through the science of implicit bias, understanding how it affects healthcare both with teaching as well as with patients, and how to combat it basically. So really fast, picture a CEO in your head. What comes to your head? Fortune 500 company, what comes to your head? What kind of person? What's their race? What's their gender? Is this what came into your head? I don't know, maybe not. For me, it was a Caucasian male when I thought about it. How about this one? Picture a mathematical engineer. I will tell you, I thought of my tall calculus teacher when I saw this one. But did you think of these guys? So, there was a movie recently out on these individuals. They make great contributions to NASA and space travel, but this is not typically what we think of when we think of mathematical engineers, being females or being African American. And recently, I have to give a plug to our social justice internal medicine team. They did a review article on, this is from 1999, I believe, on patients, similar risk profiles, only difference was gender and race. And they had cardiac risk profiles. They were deciding to go to cardiac cath or not. And the summary point, the interesting point is African-American females, though they should have gone to cath for whatever reason, whatever bias, they were the ones that were discounted or got the least amount of referrals, less than African-American males. Overall, the Caucasians were referred more frequently. And why does this happen? Why, why would this happen if they're medically, objectively, should all have gone to the cath lab? We read these kinds of quotes every day. And if I told you today someone was shot going to downtown DC, African-American shot going down to downtown DC versus healthcare worker shot, that changes how you look at it. It's kind of weird, right? You have these strange feelings or strange thoughts about it, but you don't really know where they're coming from potentially, and much like when we read these headlines, how some things are addressed, and you can read for yourselves. And I actually, so these two tables, do they look the same to you in size? If I knew how to use polls on Zoom, I would have put that poll up, but I don't. But anyway, so, oh, it's not going, so I guess it didn't go, but that's okay. These two tables are the same size. And the reason I bring this picture up is to say, when we study where we make errors, even though when they're not obvious to us, so we're making an error that's not obvious to us, we want to use that knowledge to grow to avoid those errors. So as Matt Damon said in The Martian, let's science it. We're going to define implicit bias, and we'll talk about the science a little bit. Everybody knows the story about Pavel's dog. So the dog sees food, gets hungry, eats. You know, the tuning fork. The dog is not hungry because they're just hearing this tuning fork. What does that have to do with food? But now you bring food and the tuning fork together. So every time the dog gets food, they also hear the tuning fork, and now they start to associate those things. And now when they have the tuning fork by itself, that association is made, so they start to salivate. Much how our implicit biases are made. By the way, implicit and unconscious bias are interchangeable terms. So I show the residents this one, and some of this talk is stolen from my talk for them. But when you guys drive home, if you've lived where you live for a while, you just kind of drive. Sometimes you don't even remember how you got home in a sense, because you just know how to drive home. You've done it 100 times. Drink coffee, talk on the phone, and you're home. But when you first moved to your house or your new place, wherever it might be, it was more like on the lower right, where you have to, where am I going? What lane do I get into? I have to think about it much more. And this is the implicit part of it. Our brain does so many complicated things all day. It's got to make some of this stuff easy. And driving home for the 100th time is much easier than the first time. Let's mention bias a little bit. So what's your favorite color on this? My personal favorite color is red. Somebody might like green, somebody might like purple. So you're biased towards that color. That's the color you like. Is that wrong? No. Is it good? No, it's just the color that I like. So I was trying to find 3 pretty sports cars to show, but this painting was all I could find. But that's bias. When we have a attitude towards something that could be favorable or might be unfavorable. And unconscious bias, when you bring that unconscious word into it, it's below our perception. We don't realize it's happening. Some more terms. Prejudice and stereotype are usually both thought processes. Prejudice being more of implicit or unconscious bias. Stereotype is you feel this way about this person or this group, and you are active in thinking about it. For instance, I'm an Eagles fan, so my stereotype is I like all Eagles fans. All right, but I'm actively thinking about it. Discrimination is the action you take against that other party. If you the things that you see, so discrimination is the actual action of what happens. And this is, coming to it, this is association formation. And much like our terms before, you can see, so the top article is this young male, looks African-American, he is, looting the store. We don't know what happened. I don't know if anybody interviewed him. And yet on the bottom, it's 2 Caucasians. They're trying to save their lives by finding bread and going through the store. They might have both done the same thing. But you can see by our association of what we think they're doing, that it can be a very different outcome. So these are what we're trying to figure out is why we have these biases and how to prevent them. You can read the slide, but basically the summary to me is what Dr. Banerjee says, and she wrote this book, The Blind Spot. It's a really good book. Basically, our unconscious bias develops from the thumbprint of the culture on our brains. So all your social experiences, your growing up, any experience in your life, the people that you interact with, they put a thumbprint of culture on your life. Remember I mentioned I was an Eagles fan? Well, I grew up in Philadelphia. So that's the thumbprint that put me as an Eagles fan, So that's a nice way that's just a gentle way of saying it, but this thumbprint is what affects us to have these thoughts. Now to be even more formal, remember I said we try to do these things so that our brains can have a little break, but hundreds of years ago, back in the caveman days, if you heard a growl in the woods, were you going to take 10 minutes to think about, should I run? Should I sit here? Maybe it's a nice cuddly little puppy or something, or maybe it's a saber-toothed tiger that's going to eat me. So our brain said growl, run, right? It's that fight or flight response thing, right? And so the frontal cortex, the amygdala, temporal lobes, all these things, they try to make our fast and automatic actions happen. They respond quickly. So, today, and particularly towards this talk, you can see the bottom, I have a young African-American male in a hoodie. If you see him walking down the street, what do you think? Do you have uncomfortable feelings? Do you feel like he doesn't belong in your neighborhood? But you don't really know why. Maybe you do know why. Maybe it's more of a stereotype than a prejudice. What if I showed you this picture? Someone so he walks into the hospital like this. You probably won't think twice about it. and I do like my hoodies too. I'm gonna try to move this over here. There we go. So how fast do our brains work? If you can read this paragraph, it's because our minds are very good at putting together pieces of information in a way that is easy for us to make sense of. Our minds do this automatically without our conscious control. So fortunately, I've read enough in my life to be able to my brain can put that together without thinking about it. But look, it's a grossly misspelled paragraph. But that's how it works, right? So your brain works so fast that it can do it. And coming back further, so the first couple of milliseconds when you see somebody or something, you make a decision. You can make a judgment, just like that growl, run. It's instantaneous, right? But this is non-articulated, non-conscious. As you wait, now you're more actively thinking about it. So maybe I run away and then I hide behind a rock and be like, okay, I got to figure out what to do, where to run, etc. Now, with this, there's a great study, and this is from this journal in 2015, where they did functional MRIs, right? So remember we said frontal, temporal, amygdala, right? So you can see they showed a group of people, stigmatized population. So they used alcoholics and homeless people. So they showed them a picture and they saw where their brain started to function. So within the first 2 seconds, most of the functioning was, you can see frontal lobes, amygdala, temporal lobes, and as time went on, you can see here it moved to more towards, they had more active thinking, etc. It took that they were non-stigmatized. In other words, they were more actively thinking about this. But you see the time difference. So quickly they made a decision, and it was more in the stigma area when they saw these pictures. And this is what happens again when we see a particular patient, when we're walking into the room, we hear that one-liner when we're going to the ER, etc. Sorry, this is a little bit of a complicated picture, but very to summarize it, I like to say this is the warmth of the niceness index. 5, they're really nice. Capable, or as sometimes we say, sophisticated patient. They know what they're doing. So let's take the patient with Alzheimer's. So they might be very nice, but they probably, you'll feel they're not very competent, right? So the patient is well-meaning, they're ineffectual, but you feel towards them, your bias might be, I feel sorry for this person. And then you might be paternalistic, overly controlling. When I did my residency at UConn, we also took care of Department of Corrections patients, right? DOC patients. So if I met a violent criminal in the room and I was taking care of their, kidney function or whatever, maybe they're threatening me, maybe they're untrustworthy. So what do? Well, I might provide them inferior care just because of this bias that I have that makes me have contempt for them. In group, people that are similar to us, we tend to treat very well. And that's kind of what's up here. So just a summary of how we can provide poor or not adequate healthcare to certain patients, because we kind of brush them aside. All right, and we discussed this. So people that are similar to me, I tend to treat better. That's what my biases want me to favor. There are many biases, and for me, one of the things that I've really learned and want to work on is LGBTQ community and understanding their struggles and what they go through. We talk about gender, we talk about ethnicity a lot, how about people with disability if you see somebody in a wheelchair. So there are many ones, and we'll talk about more biases as we go forward. I mentioned this a little bit, but remember, explicit and implicit bias are 2 different things. Explicit is out there. You can see some examples here of explicit bias. Implicit is, again, below the water. It's the iceberg you don't see. It's in the unconscious. So remember that. Moving towards medicine, the medical field, biases in medicine. There are many stakeholders. This is not just the physician, the nurse, the CNA. This is all of our staff, everybody that works in the hospital, but everybody else that comes to the hospital, including of course, our patients and their family and friends. So this is a report recently from, I think, the last 4 or 5 years ago about the medical school applicants and their diversity. Let's take a look at our workforce. So you can see the majority of medical students are white. And then the next number that's up is Asian. Still almost a drop of half. And then if you go to Blacks and Hispanics, though it's slowly going up, much, much lower groups. So we do have, everybody's working on improving the diversity, and there are different reasons for these numbers. But remember, one of the reasons that we have bias is that we are not similar to the patients that we see at times. So we're trying to develop, try hopefully in years to come, a more diverse workforce. And one of the things that actually the playing field has leveled a little bit is that for the first time ever last year in 2019, the majority of medical students were female. What kind of stuff happens with implicit bias at work, or unconscious bias? Our interpersonal interactions, internal dynamics, considering a considerable loss of money spent on different things due to bias, due to this, And and again, other costs to the providers, increased burnout, higher rates of depression and anxiety. Patients, health disparities. I work in transplant, as everybody knows, there are a lot of health disparities and in transplant, and here, workforce that we talked about already, it doesn't reflect our population per se. And there's a slide here, but really, this is what I wanted to take on point of the slide. Prejudice is a great time saver. You can form opinions without having to get the facts. We've all done it when we've gone to the ER and we had a frequent flyer and like, oh, they're in for this again. Sometimes we brush them off, and sometimes there's something totally different going on. Sometimes if you had a bad experience with a medical student from a certain school, then the next student that comes from that school, maybe they don't get a fair shake. And this brings me towards recruitment bias. So when we are recruiting staff, when we're even talking to patients or medical students, or soon to be when we interview our residents and fellows to be, what kind of biases could be present there? So this is a case study from the early 2000s. Heidi and Howard have the same exact CV, same everything. The only difference is that Howard male, Heidi is female. Okay. And I do want to mention, obviously other people are non-binary, and this is binary, but there are other parts to that area as well. But coming back to this, so Howard, he's a competent, and I want to work with him. I really like him. So he got all the jobs. Why didn't Heidi get it? Well, she's female, and yeah, she's competent, but I don't work for her. She's a gunner. She's a go-getter. She might be difficult to work with. She might not have, might not be fun to be around. So I don't really like her. So, and then it was interesting when we were talking to the residents, I forget the resident, but she told me a story where, a female resident was in the back room, the lecture hall, and 3 of the students on front, 1 girl, 2 guys. These 3 in the front were asking all the questions to the professor. And so our resident asked to her friend, why is that girl asking all those questions, man? We want to get out of class. And, is she a gunner or something? But the funny part was her friend turns to her and says, well, the two guys are asking even more questions. Why didn't you think that was wrong? Why didn't you think that was an issue? So we all have our biases. And, they've done this with different things like race or sexual identification, orientation, what gender you are. So as it is in this case. But yeah, when we write letters of recommendation, or when we talk about people in evaluations, you can read this, but one of the things I really notice is this. So with women, we tend to say they're a grinder, they're compassionate, they're caring, more like very homely, very loving. But guys, oh, the guy has a lot of ability. He's so successful. His achievement is amazing. He did this and this and this. And this is a stereotype that we use, so it's okay to describe men this way, and some of the words we try to avoid when writing letters now, and I've learned this year with the BRIC community, is you can see words to somewhat avoid and words to include. Remember, bias is not good or bad per se, but you want to give everybody a fair shake. And for me, I think about patients when I say they're non-compliant, or other terms that we use in the EMR, the electronic medical records, to say that, that might hinder a patient's care, a year from now, 2 years from now, and they might be unjustifiably have this label put on them. There are many biases in the workplace, but it comes back really to summarize all these is in group. So when I look at a resume, when I make my judgment, I will look for things that agree with that judgment. If this is the best student ever, I'll look for stuff to make sure that I believe after looking at the resume, they're the best student ever. That's why one of the things when you interview a friend, or you try to bring a friend over, your objectivity sometimes goes away. You just look for the reasons they should be there. Many times because they're similar to you, they agree with you, things like that, as opposed to being the opposite. There are other biases as well, such as like the horns effect, right? So an intern presents morning report and they don't do a very good job the first day. Well, now you think every time they do morning report, they're not going to do a good job. So that's the horns bias effect. Like they're always going to be bad. Halo effect. Patient comes in, patient comes in the first day, everything goes great, and then you're like, well, this is going to be a great relationship. Everything's going to go well. Then then bad things happen. They show up, they don't come on time, or they miss their medication. They're like, doc, I'm a good guy. I'm going to do my thing. And because that first interaction was so good, you might not call them out, or you might not take better care of them because you'll assume that they're just doing the right thing. And there are different biases here as well, as you see. So how do we recognize these biases? Well, let's take a quick test. All right, so I'm going to show you some pictures. And again, I don't know how to work polls, so you guys can make fun of me later. But we're going to just say if it's pleasant or unpleasant, okay? So a mosquito, right? What do you think immediately? And I have a lot of mosquito bites on me these days. All right, another picture. Flowers, what do you think? So most of you, when you saw the mosquito, I'm assuming, were thinking it's unpleasant, and it was instantaneous. As opposed to flowers, it was pleasant, right? And this is, so the first thing when we try to fight bias is recognize when we have a bias, right? And this is the purpose of the implicit association test developed by Dr. Anthony Greenwald in the late 90s. This is not a perfect test by any means. Basically, you can see the pictures here and the words here. They'll put some words there and you have to click left or right and the picture shows up, and then whatever you think immediately, you're supposed to click. And the latency period is how they calculate your bias. So you use several of these pictures, and it's actually at Project Implicity. You can take these, there's a free bunch of tests you can take, and you can see there's quite a few on the bottom. And they do ask you your preferences prior to taking it. So for instance, do you prefer whites, blacks, or you are equal to both? And this, again, because it's asking you to decide so quickly, it's going after this, your implicit bias. And as I said, it's controversial, but this really hit home to me when I came across this slide as I prepared for the talk. How do patients rate their interactions with physicians with implicit bias? So a few physicians, in this study, I think 3 or 4 or 5, something like that, they have, several hundred patients. The physicians took the implicit association test. The patients took a survey, how they were treated basically. And you can see, so those physicians who strongly preferred blacks, the patients felt better treatment, communication, trust, contextual knowledge. On the other side, and whites were the baseline, those who had strongly preferred whites, the black patients did not have such a good interaction with. And with Latino patients, there wasn't much of a difference. The point to me is not maybe necessarily that this test is perfect. The point to me is if I scored here, is to ask myself, really look at myself. I mean, if I scored here, yes. If I to really look at myself and say, do I have a bias? Should I ask around my other colleagues, did they say, do you ever notice me having a bias against these type of patients or anything like that? And that's something to recognize. So you're recognizing you have a bias, because then you can only do something when you know that it's there. All right. And this is a visual abstract that I made for this study. You guys are welcome to ask me to help make one. I'm not the best at these, but I do try my hand at them occasionally. It's basically making a written abstract into a visual picture as opposed to just putting a PowerPoint up with graphs and words. Anyway, so Dr. Capers was at the Ohio State University, part of the medical school admissions team. And his question was, what is the effect of implicit bias on medical school admissions? So they have about 140 members, faculty and medical students, and he asked them to take the implicit association test. This study looked at race, but he also discussed gender and sexual orientation. They all completed it. They did, I think, a post-trial as well, post-survey, sorry. These numbers here, so this is the numbers, they show what they mean here. But anyway, the higher this number, the more likely they favored whites, or they disfavored black applicants. And you can see the biggest group was the faculty that had a bias against them, right? So they all favored white applicants. And one interesting part was how the difference between the medical students, they had half the level of implicit bias versus the faculty. And you can see post-admission what a few of them said. And the thing is, I understand I might have a bias here. Let me see what I can do to counteract it. And an important point as we look for, when you do different hires, whether it be looking at residency, medical students, or for your facility, you wanted a diverse group. You don't want a group of all one type, and otherwise, that's the best way to have a good choice or a person, or include diversity in your choosing process. These pictures, which one of these pictures make you comfortable, uncomfortable, right? Many of us are used to certain roles here, and the thing that's interesting is, remember they also looked at gender in that trial. All the women, faculty and students, thought that men were more associated with career versus women. Women were more associated with home and family. Very interesting, because these are all women with a great career. And you would think that they would be neutral, right? So many times when you take that implicit association trial or think about it, you don't realize that you have sometimes biases against your own in-group or people similar to you. And these are just comments made and showing you the controversy with using this. This person was insulted by it, and they work with many people. How can I have this bias? Studying about implicit bias, unconscious bias, and I'll come to this, it's not a silver bullet. It's not a cure-all, and people put it down, the training, because of that. It's just part of everything else, right? Just like everything, when you learn 1 + 1 is 2, addition, you don't know all of math. Similar to that, that's the case here. So just take it, have a growth mentality, and be like, do I really have that bias? Do I really, Do I do anything that shows that I have that bias? And maybe you don't show it in every situation, and that's why it's different. We talked about awareness, how to mitigate unconscious bias. We're going to point towards the medical residents and students interviews for fellowship and residency. And then of course, always check in on yourself. So I've said this over and over again, recognize your bias is the first part of it. Pause, take a moment, recognize that bias, and think of how to counteract it. There are multiple biases here, you can read them, but if I had a 60-year-old applicant when I was an intern, my co-intern was 60 years old. Would you punish her for being 60? What about the African-American female from a small medical school? Are you going to take them in your residency? Are you going to be hung up on the fact that maybe they're from a smaller med school? They're not from, a school like Georgetown per se. The student from Harvard, oh, wow, we can have a student from Harvard here. We should definitely take them. Is that going to give you too much of a positive bias? If they come in a wheelchair, is it going to affect you? And I know, and there are other, if they have a partner, does that change how you think about a particular applicant in any way? There are some legal questions we don't ask them, which is totally fine. But I also want to apply this to patients. How many times do patients come in and we already, for instance, in transplant, if someone comes in and says, I don't have the social support, I don't have this or that, we try to work with them to get there. We don't just say, no, this is not going to happen. We try to say, okay, let's work on this to give you a plan to get to the point where you can get a transplant, not hopefully just brush them off, or the non-compliant patient. Why were you non-compliant? What happened? Why is this word in your history? This is some ways to reduce implicit bias on interviews and for med school and for residency, fellowships, etc. Some schools are doing these, like removing photos, removing academic metrics. That's more controversial. I'm going to keep it a little simpler and just talk about, consider taking the implicit association trial testing. And also I'm going to give you this little cheat sheet that I made. My biggest tip for me is when I interview somebody, I try to go through their resume and write down what I think. And then I try to look through it again to consider the opposite point of view, or try to find a connection with them. If they're very different than me, there's got to be, look for something that connects me, so I remove any negative implicit bias that way. Think of somebody in their community that I admire, they admire, again, bringing them into, we're in the same group, same membership. And of course, understanding where someone comes from. Not everybody, they always say not everybody is born with a silver spoon or such. So not to understand how someone built themselves out, how someone made a career for themselves. There's a story recently in, I think, Teen Vogue about a medical student, that just started, their African-American young male. He was actually the security guard while he was an undergrad. And because one surgical resident took the time to bring him to the OR, really changed his life. And now he was just studying and gave him away. And he's now walking up the same place he guarded to go in as a student, as a medical student, So I think these are really important things to do. They're not a cure-all, but it's a start. So I had to throw in a kidney transplant joke. You guys probably all seen the slide. One kidney to the other. I'll miss you, my old friend. Don't worry, it's for a noble cause that you're getting donated. And another kidney says, donating yourself to save a life is very selfless. But of course, the other kidney says, wait a minute. I thought you were getting donated. Me? No way, dude. I like it here. I'm staying here. So anyway, I had to throw in a transplant slide. No acid base. Don't worry about it. Examples of biases by medical professionals towards patients. So you can read the bold thing. So medical students' implicit racial bias remains constant or increases, over time. But Black patients perceived to have less pain. This has been shown in many ways, and you've probably heard this in the news recently. As we showed in the beginning, similar cardiac risk factors, there's a gender bias. Maternal and child health care outcomes that can be affected by implicit bias. There's another story where people there was a very suburban area with mostly mostly a Caucasian population. They had a drug problem, and they set up a lot of facilities to help those people, which was great, as opposed to the inner city where there was not that support per se, and it was more, let's increase jail time for people caught with drugs. So these are how implicit bias really affects things in the world today. Oops, sorry. Now, when I go for an interview to interview a patient, we're coming now to patient care more, and this probably also can be in other areas. But I want to point out a couple of things. So sometimes it's less. So this is me towards the patient. So my speaking time to a patient that I might be biased against might be less. But note, I, the physician, will do all the talking. Okay, or whoever, the advanced practitioner, whoever might be taking care of that patient. Also, on the other side, you see, like, so how many times have we said to a patient, we are going to take this medicine, right? And then when I think about it, I'm like, that's kind of condescending, and instead of saying, you, Mr. Thomas, will take your medicine, So we have to be careful of these things that we do even in the room, and we don't realize it. We might not realize it. Now, this is a little more into my world. Recently, there's been a lot of controversy in nephrology about using the estimated GFR formula. The University of Wisconsin, Vanderbilt have already gotten away from using race in there. So you see, when we get our estimated GFR, we use the CKD epi formula for those that want to be fancy, but we do put the construct in there of race. So typically about 15 to 20% African Americans will have a GFR more than a Caucasian. So I mean, I don't know what I would do because I'm Indian. So where do I fit in? So that's one way that's kind of, where would you put my GFR? The other thing is, what about transplant? So if African Americans higher, their GFR, you get listed for a transplant at 20, a GFR of 20. So if you're the same size African American or Caucasian male, and so the Caucasian will have a lower GFR, 20, because they don't have this extra multiple factor in there, and the African American will be 25. So I will now list the Caucasian, but I have to wait for the African American person to come down to a GFR of 20, or male or female to come down to a GFR of 20, but they might be the same size, and that's why that construct was made, because the idea that African Americans are bigger than Caucasians, and that's why they put in this multiple so that the GFR would be higher, becomes higher. So what if you remove it? Well, if I remove it, it makes the GFR the same, but maybe it really should be there in some way. Well, then it could change it might shorten how many people we qualify for living donation, African Americans. And you can see this graph. The main point is there's no real right answer right now. We use what we have, but remember, this is, we counsel them. The other part is they talked about race when I learned about GFR, but I never looked at it that way. And in a sense, that's like implicit bias. And you can see here, recently our pulmonary friends probably definitely know way better than me, but there's an association of dark skin having a change in that pulse ox sat, it might be 5 to 8% off. Today I was shown this picture, and you can see we learned about target lesions in med school, right? But in African Americans, you're not going to see that, or darker skinned folks like me, you're not going to see those lesions. So remember that race is a construct. So in the early 1900s, when Italians came here, they were not considered white or Caucasian. They weren't. They were considered non, right? So using race as a social construct also in medicine can be dangerous. It probably has some role to play, but we always present patients as African American, Caucasian, and sometimes that might change us or bias us towards one way or the other. So remember that race is a social construct, not a scientific classification. So much like with interviews, it's the same idea. Take the identity of your patient, understand their identity. If you have an opinion about a patient and they're new to you or they're old to you, go into the room and say, like, what, everybody in this guy or this female's chart has said, they're non-compliant. It's all over the chart. Well, what if you go into the room and say, I'm going to prove that they're a compliant patient? That's what I'm going to go in with. That might change the whole interaction. And, that's what we're supposed to do. We're supposed to advocate for our patients. And this is a story for me that I'll tell you, and this is why it's very important. So when I was at the University of Maryland, I had a young Black male patient who came to me, history of drug abuse, quote unquote, non-compliant with medications, missing their dialysis treatments, coming off early, okay? These are all, we need compliance in transplant because you got to take your medicines, otherwise you obviously will lose the organ, right? So the idea here is pause, take a moment, ask them, do a good history, what's really going on, okay? And see all these biases. So everyone says this patient is not compliant. So my group says they're not compliant. So why am I going to fight and say they are compliant? I need some details, some data, right? What if the patient is very unkempt, doesn't look great that day, doesn't come in a suit or something? Would that affect it? On the other hand, what if they went to the same college as I did? Now I favor them. The Horn effect. Well, look, they have a history of IV drug abuse, non-compliance. So those things, that's it. This is a horrible patient. No, we should not transplant them at all. You want to find out more details. Anyway, so after you talk to the patient and you ask them why you're not, they haven't used drugs in forever, and they tell you, well, the reason I signed off early is so I got to go pick up my kid because I don't have daycare. Kind of changes how you look at the patient, right? If anything, they'd probably be more compliant than anybody else. This happened to me actually also in another case is the same, very similar situation. Patient had a rejection. I asked Mr. Thomas, I said, Mr. Thomas, why did you miss your medicine? And he told me, well, I either buy the asthma medicine for my daughter or my medicine. So what did you think I picked? Well, I'm not going to put non-compliant in that person's chart then, right? Because it's different. So you have to give them some empathy about patients and advocate for them and see what's going on to help them. I always love this one. I'm glad this is why, this is one of the reasons I'm glad I've moved on from residency, so I don't have to sit in the EMR trying to admit people. I still remember the days of the paper, the paper HMP. I'm going to quickly go through microaggressions. I know this will probably a little bit of overload. I'm going to tell you the story of how this kind of came about. So the way this came about was one of the stories of it, however, is Dr. Seuss. He's a psychiatrist, I believe, in Colombia. Him and his African-American friend went on a plane. And they sat in the plane was empty. So the white stewardess said, "Hey, it's fine, totally fine to sit in the front." So they sit in the front, and then these three white guys get on the plane and they sit right in front of them. And the stewardess asked them, "Can you guys move to the back?" And then they kind of look at each other like, "Why? That plane's empty. Why do we need to move?" And she said, "Well, you got to balance out the weight of the plane." And so the question is, was she being racist? Because her reasoning was, well, we have to balance the weight of the plane with these three people in their appropriate seats in the front. Or was she being racist? Was she doing her job? So microaggressions many times are things people do that they don't realize that are an aggression or something bad or an insult towards someone. So you can see I've put the definition and some examples here. For instance, where are you from? I've thought about how I ask that now much more. If I ask someone who's not from the States, maybe they'll take that offensively. Maybe if they're an immigrant like me, even though, immigrant's kid, they might take that offensively. And there are different things here that you can see. And here are some other, there's a project that takes a lot of these pictures. Do you speak English? You're good with numbers for the Asian guy, right? And there are various ones, and everyone experiences this. How do you combat it? Well, some of the things for us as attendings or residents, when you're on the floors in the hospital, just establish a culture. You might not necessarily have to speak it out, but you want to create a culture where they're not tolerated microaggressions or even a bias, implicit bias, and that people can approach and discuss these things. So I've left a quote up there, but it's really to acknowledge when these things happen. If when you go into a room and your female resident is they call the female resident by the first name and not Dr. So-and-so, for instance. You might want to tell the patient, "Hey, this is my resident, this is my, attending, my physician," and give them the respect. I think for many of our trainees, it's acknowledging that this happened that really helps them. And here are some other microaggressions that we see. And one of the things that I've really worked on recently is, what fellowship do you want to do? So not that they need to all do nephrology, or transplant or anything, but how many times we hear someone say, "I want to do primary care," and then we may look at them differently, like, "Why do you want to do primary care?" For instance, it's a great field, be supportive, but that can become across as a microaggression. Other one, particularly for residents, "You look too young to be a doctor," for things like, there are many things, for advanced practitioners, if we ever be careful of sometimes what we say to them as well. They're all well trained as well. So there are many of these examples that you'll see. The main thing is trying to, if it happens to you, if you have a microaggression against yourself, is try to have an even tone, to really focus on the situation or the issue or the behavior, not the person, right? They might not even know they're doing it. And that's one of the things with microaggressions to realize. So this is from Dean Cheng, actually. So stop, just what you say, pause, think about it, recognize something might have happened, and talk to them or talk to a superior, see what can happen, and then judge how you want to move forward with the situation. Remember, don't make it combative. If you need to take a moment, take a moment. If something happens in a patient's room, make sure the patient's safe, step away, and if you have to continue to see them, continue to see them. If it's not fruitful and it's not good, then you have to think of a way out of that. But remember, particularly with patients, always make sure that they're safe. So we're almost done in summary. So this is Dr. Mona Hannah Atisha. I hope I said her name correctly. So she was a pediatrician in Flint, Michigan. She went to a barbecue where one of her friends that worked for the EPA said, "Hey, they changed the water supply up here." And then she found through her own patients that the lead levels had come strikingly very high. She was the whistleblower in Flint, Michigan, because of people that are of economic status is lower, to save money, the city did this. Not to get into details, but really the main point is she advocated for her patients. So whatever our role in healthcare, that's the thing that we want to do. We want to advocate for our patients, for the people that we take care of, to make it a better place for them and for us. As to summarize, we talked about implicit bias. It's a cognitive shortcut to what your brain wants to go to. We might understand the stimulus, but we just take an action, and this can be a discriminatory action, as opposed to pausing, thinking about it, doing active thinking, and then taking action. So, and we talked about all these things. So recognize you have a bias, take the implicit trial, sit down and look at a resume or a patient and see if you have bias against them, try to prove the opposite, increase awareness of it, and understand that this is associative learning from our cultural thumbprint through the course of our lives. And again, it's not a silver bullet. Unconscious bias training, implicit bias training, there's plenty of articles saying it doesn't work, right? But I hope that that everyone who's listened can understand, maybe I do have biases. That's a good, if I did that, that's a great start. And then how do I counteract those? That's the second great start. And just try to move on with those things. And I think this was another trial they did when they did the implicit bias training. And if you look, this person takes the extra time to think to myself, why is this bothering me? Why do I feel this way? They reflect and put themselves in the situation of the other person, having better empathy and understanding for the person's experience. A couple of plugs. This is for Dean Chang and Dr. Graves, the Office of Diversity. They have a lot of cool things. You can go through the med school for that. You can just Google them, of course. They had a bunch of programs this year. They have a Twitter account. Also, we're doing another one on intersectionalism, which is something, which is another topic. They have different things like open spaces, learn-ins, dialogues, all this kind of stuff, very cool stuff. And I hope you guys have the PowerPoint so you can take a look at these later. And I want to read this quote and then I'll finish up. Even the most well-intentioned person unwittingly allows unconscious thoughts and feelings to influence apparently objective decisions. And that's what you want to understand that and move forward from it and try to come across with ways to make yourself a better evaluator in every way for our patients, for our residents, students, and that's all. You guys also can follow me on Twitter at bthomas215. Thank you, everybody. I really appreciate your time today.